My dear students, welcome. We are on the fourth session of anti-cancer drugs. So what I would advise you is, if you are not visualized the previous ones, 1 to 3, it's better to go to those particular sessions and then come to this, because we already discussed many anti-cancer agents. On this fourth session, we continue with the anti-cancer drugs, and the first issue for discussion is the monoclonal antibodies and interferons useful in various cancers. And if you have a look at the slide, I made a list of some monoclonal antibodies as well as alpha interferon on the slide. Since these monoclonal antibodies are specific against a particular receptor or a particular antigen, you need to remember it. You need to practice to memorize which particular antibody for which antigen and for which carcinoma. Gemtuzumab is useful against CD33 plus myeloid leukemias. The next one is alemtuzumab, and it is useful against CD52 B cell CLL. Alemtuzumab, CD52 B cell CLL. The next one is rituximab, and rituximab is specific for lymphomas. It's an antibody to the surface protein of lymphocytes, and the specific antigen is CD20 antigen. So rituximab for CD20 plus lymphomas. Next one is trastuzumab, and you might have heard it. Trastuzumab is a human epidermal growth factor receptor 2 protein monoclonal antibody. So it's a monoclonal antibody against the HER2 protein. It blocks the HER2 protein receptor and it's useful in breast cancer. And lastly, this alpha interferon, which is used in leukemias, which is used in CML, and which is also used in T-cell lymphomas. Let's revise once again, just say it once again so that you hear it and it's helpful for you to remember. Gemtuzumab, CD33 plus myeloid leukemias. Alemtuzumab, CD52 plus B cell CLL. Rituximab for CD20 plus lymphomas. And trastuzumab is HER2 surface protein receptor blocker for breast cancer. Alpha interferon for leukemia, for CML, and for T-cell lymphomas. I want to have a word with you about CML, chronic myelogenous leukemia. There are some drugs which are used in CML, and it's worthwhile to do these drugs because we are not doing many of these drugs as individual agents in our discussion. One of the drugs used in CML is hydroxyurea. It's a urea analog, and it mainly acts on the S phase. It's used by oral route of administration, also adjunct with radiation therapy for head neck cancers, and it's used in CML. The second drug useful in CML is called busulfan, is an alkylating agent. The third, comparatively newer agent is called imatinib, and this imatinib inhibits an abnormal tyrosine kinase. This abnormal tyrosine kinase pathology was discovered, and then we also had this drug which is specific to inhibit the abnormal tyrosine kinase. This abnormal tyrosine kinase is created by the Philadelphia chromosome abnormality in the CML. So imatinib inhibits tyrosine kinase. You could remember this particular mechanism of action for imatinib in CML. And these are the three drugs for CML: hydroxyurea, busulfan, and imatinib. And when you come to CLL, I'm reminding you the drug of choice for CLL is chlorambucil. So that's about CML and CLL. Now we have a brief discussion on L-asparaginase, which is used by intramuscular and intravenous route of administration. What does L-asparaginase do? It catalyzes the reaction asparagine to aspartic acid plus ammonia. So that's deamination. Catalyzes the conversion of asparagine into aspartic acid and pneumonia. And the enzyme asparaginase is derived from the bacteria. Some cancer cells, they need to take asparaginase from outside, from the exogenous source. And if you use this particular drug, L-asparaginase, then what's going to happen is L-asparaginase is going to hydrolyze the asparagine in the blood. it will hydrolyze the blood asparagine, and then asparagine will not be available for the cell. So asparagine is an important nutrient for the cell, and asparagine to aspartic acid is the conversion done by L-asparaginase, and when you'll give L-asparaginase, is going to hydrolyze the blood asparagine and it's going to deprive the cell of this cell nutrient. So cells won't get the required asparagine. L-asparaginase is useful in childhood ALL as well as the childhood lymphomas. Adverse reactions include hypersensitivity reaction. Meanwhile, it's derived from the bacteria. So there's antigenicity, there's hypersensitivity reaction. It leads to decrease in the clotting factors. It can produce the toxicity of the liver as well as pancreas. It can lead to pancreatitis and ammonia production. So these are some adverse effects of L-asparagine. Now we move on to the next slide, and here we are going to review many anti-cancer drugs, and we are going to review their toxicity in details. And I am sure these tables are going to work well, and they are going to be useful to you, because we have an anti-cancer drug and we have toxicity, because we went through swimming through various chapters, and now we are trying to consolidate and bring some important facts to our mind. The first drug is an alkylating agent, and that's cyclophosphamide. And you can close your eyes and you can give a mental exercise to yourself before looking at the slide if you remember any toxicity. Cyclophosphamide specifically produces hemorrhagic cystitis, and this hemorrhagic cystitis is due to acrolein content. And to prevent this toxicity, you can do many things. Number one is you can increase the water intake, or you can use a substance which can prevent the toxicity. And the name of the substance is MESNA. That's mercaptoethane sulfonate. That's MESNA. Cyclophosphamide also produces cardiac and pulmonary toxicity. Please mind well, we are not going to express all the general toxicity of the anti-cancer drugs. We are going to restrict to the specific toxicities. Of course, any drug produces more bone marrow suppression, less bone marrow suppression. We shall speak about it. So cyclophosphamide hemorrhagic cystitis, and the drug to prevent this toxicity is MESNA. So cyclophosphamide hemorrhagic cystitis, MESNA. Second drug is busulfan. An important characteristic toxicity of busulfan is pulmonary fibrosis. Other toxicities include adrenal insufficiency and skin pigmentation, but specific for busulfan, pulmonary fibrosis. Next we go to cisplatin and carboplatin. Let's first go to carboplatin, so it becomes easy. Carboplatin B, bone marrow suppression. More bone marrow suppression. More bone marrow suppression, and other toxicities are less. Other toxicities include ototoxicity and nephrotoxicity. When I say other toxicities are less than whom? Less than cisplatin, because cisplatin and carboplatin is a pair, the drugs acting by the same mechanism of action. So carboplatin, more bone marrow suppression than cisplatin, less ototoxicity, nephrotoxicity than cisplatin. Let's go up, that's cisplatin, and cisplatin produces less bone marrow toxicity and more ototoxicity and nephrotoxicity. So you can see here in front of cisplatin, less bone marrow toxicity and more nephrotoxicity and ototoxicity. In ototoxicity, you get acoustic as well as the peripheral neuropathy. In addition to this, most important thing we must remember about cisplatin, that cisplatin is a very potent emetic. So it produces severe nausea and vomiting, and we need to do something to block this nausea and vomiting. Cisplatin mainly produces nephrotoxicity and ototoxicity, and just like we have MESNA to prevent cyclophosphamide toxicity, to prevent the cisplatin toxicity, we have a drug called amifostin. So remember this pair, cyclophosphamide, MESNA, cisplatin, amifostin. We move on to the next row, the last row on this slide, that's methotrexate. And please remember, it's a folic acid antagonist and inhibits the synthesis, and naturally you are going to have bone marrow suppression, severe mucositis, crystalluria, And because it's a folic acid antagonist, you can get folinic crisis. And to prevent this toxicity of methotrexate, especially the folinic crisis, we need to use folinic acid, and that's nothing but leucovorin. And this is called leucovorin rescue. And the toxicity is enhanced by the highly plasma protein binding drugs, because methotrexate is also highly plasma protein binding. The other highly plasma protein binding agents can displace methotrexate from the protein binding sites in the plasma, and the methotrexate levels can rise. Folic acid antagonist can produce the folinic crisis, and to prevent this toxicity, we use folinic acid or leucovorin, or it's also called citrovorum factor. On the next slide, we have some more anti-cancer agents. And the first one is bleomycin. And I made this B from bleomycin blue to make you remember blisters. Bleomycin produces blisters. Bleomycin produces pulmonary fibrosis and hypersensitivity reactions and hardening of the skin. So skin reactions, including the blister formation, is typical for bleomycin. This is the only example, I tried to use this B for bone marrow and B for blisters and other things. This is the only example where the drug is containing B in its spelling, but it's less bone marrow toxic. I'll remind you, bleomycin is a less bone marrow toxic agent, and its important toxicity to remember is the skin, that's hardening of the skin and blister formation, and the next one is pulmonary fibrosis. Next we move on to doxorubicin, which is also called adriamycin. So doxorubicin, daunorubicin, the anthracycline antibiotics. And we said they are very specific for cardiotoxicity. So doxorubicin or adriamycin is cardiotoxic. This happens due to the formation of the free radicals, and it leads to delayed cardiomyopathy and delayed heart failure, congestive heart failure. And to prevent the toxicity, we again use a drug. Again, it starts with the spelling D, just as doxorubicin, and the name of the drug is dexrazoxane. So doxorubicin, to prevent the cardiomyopathy and to prevent the cardiotoxicity, is dexrazoxane. Dexrazoxane can prevent it because dexrazoxane reduces or inhibits the free radical formation by doxorubicin, which is responsible for cardiomyopathy. Next we move on to a pair, just like we discussed cisplatin, carboplatin. Let's move on to a pair, vincristine, vinblastin. These are vinca alkaloids. They are spindle poisons acting on the M phase. And between vincristine and vinblastin, I hope you are looking at the slide. Between vincristine and vinblastin, this B indicates it's got more bone marrow suppression. So vinblastin, bone marrow suppression. And since bone marrow suppression is more, the rest of the toxicity is less, thus neurotoxicity is less. Now let's come to the other drug in the pair, that's vincristine. Vincristine doesn't have B, so it's less bone marrow toxic and it's more neurotoxic. So let's discuss the neurotoxicity of vincristine. It's diminished reflexes, peripheral neuropathy, and also autonomic neuropathy in the form of paralytic ileus. So I think this B bone marrow is going to be helpful to you. Only take care about bleomycin. In spite of having B, it's not bone marrow toxic agent, but this B stands for blisters, and it could also stand for the fibrosis B, that's pulmonary fibrosis. The last agent on the slide is paclitaxel, and paclitaxel is very specific. It is known to produce sensory neuropathies. So paclitaxel, sensory neuropathy. Now, the next slide is making this chapter still more interesting, and I hope it's going to help you. What we did until now was, we first looked at a drug and we tried to remember the toxicity. That's okay, but every time if you have to think about a toxicity, you have to first remember the drug and then you are going to remember the toxicity. This is how probably your brain is going to be trained, but it has to be trained in another way. That's the opposite way. And the opposite way is, I ask you which particular drug produces pulmonary toxicity, which drug produces cardiotoxicity. This way also you need to train your brain. So this table is in the reverse manner. The first column is showing you which toxicity, and the second column is showing you which drugs are most likely to produce this. So we start with renal toxicity, that's nephrotoxicity. One of the most important, most nephrotoxic agent is cisplatin. And the second nephrotoxic agent is methotrexate. So once you think of nephro, please don't forget cisplatin, that's nephrotoxic. Next one, bone marrow suppression. We are going to mention the drugs which produce bone marrow suppression. And you have, whatever we try to make it up, like using the spelling, using the alphabet B. You have your vinblastine here, I'm showing you the cursor, and you also have your carboplatin here. So those two B's are here, vinblastine and carboplatin. Apart from this, which are the other bone marrow toxic agent? Easy way to remember is most of the alkylating agents, they do produce bone marrow suppression. That's nitrosourea and cyclophosphamide. Next, we think logically, the drugs which are going to be anti-metabolites and are going to affect the DNA synthesis, they are all going to be bone marrow toxic. So let's choose the anti-metabolites from this list. You have cytarabine here, you have methotrexate, you have 5-fluorouracil, and you have 6-mercaptopurine. See, this is how we can resolve it, and it will be easy for us to remember. So as I said, vinblastine, carboplatin, the two B's, then alkylating agents, nitrosourea and cyclophosphamide. Then the drugs which are going to inhibit DNA synthesis, that's cytarabine and methotrexate and 5-FU and 6-MP. And then what is remaining here is doxorubicin, procarbazine and etoposide. All these drugs are bone marrow toxic agents. Let's move on to the next row. Here we have the drugs which are hepatotoxic. This is a little rare. Hepatotoxic agents is 6-mercaptopurine, busulfan and cyclophosphamide. They can produce hepatotoxicity. Although I have not written here on this slide, you can also add methotrexate to this list. Methotrexate also does produce hepatotoxicity. Next one is pulmonary toxicity, and this pulmonary toxicity is mainly in terms of pulmonary fibrosis. This fibrosis B will help you to remember B, bleomycin, and B, busulfan, at least two important agents. And the last one, procarbazine, also fortunately contains B, so you could remember pulmonary fibrosis. Next, cardiotoxicity, that's going to be easy. That's our adriamycin, that's the anthracycline group of antibiotics. Doxorubicin or adriamycin and daunorubicin, cardiotoxicity. Neurotoxicity in the form of diminishing the reflexes, and in terms of foot drop, you have vincristine, cisplatin and paclitaxel. Drugs which suppress the immune system profoundly, you have cyclophosphamide and methotrexate. And in the last column, some miscellaneous drugs are included which are important to be remembered. Hemorrhagic cystitis, cyclophosphamide, pancreatitis, asparaginase, blister formation in the skin, that's bleomycin, and some leukomogenic effect, procarbazine. So this is how I'm making efforts for you to remember the toxicity and the drug which is producing this toxicity. Next we move on to the next slide. We discuss what are the modes of resistance. What is the mechanism of resistance by the anti-cancer cells. Let's concentrate on the table. Etoposide, methotrexate and vinca alkaloids, for all of them, because they have got a target enzyme, the cells either increase the level or decrease the binding affinity of the target enzyme. Again, methotrexate, alkylating agents and dactinomycin, for all these agents, what the cancer cells do is they decrease the drug accumulation or permeability of the drug, and as far as methotrexate is concerned, they increase the DHFR enzyme, that's dihydrofolate reductase enzyme. This is the enzyme supposed to be inhibited by methotrexate. Then we go to the next row, that's purine and pyrimidine antimetabolites. There's formation of drug inactivating enzymes as far as 6-MP and 5-FU is concerned, because these drugs have to get activated. The cells can form the drug inactivating enzymes. Secondly, there can be a mutation to produce absence of the bioactivating enzymes. As I said, these drugs have to get activated in the cell. and the drug will need an enzyme. So if the cell undergoes mutation and produces absence of bioactivating enzymes, so less bioactivation. Next, alkylating agents, bleomycin, cisplatin and adriamycin. There is production of reactive chemicals that can trap the drug. So that's a novel mechanism of resistance. And lastly, the alkylating agents and cisplatin, there is improvement in the nucleic acid repair mechanism. So these drugs are going to affect the DNA repair, so the cells can improve the DNA repair mechanism. So the various modes, mechanisms of resistance by the anti-cancer cells. What is multi-drug resistance? If there is an increased expression of a gene, a specific gene, which is a multi-drug resistant gene, MDRI gene, for the cell surface glycoproteins, then there is going to be more effect of the P-glycoprotein transporter. And this P-glycoprotein transporter is involved in the drug efflux. So the P-glycoprotein drug transporters, they are using the ATP to drive the drug molecules out of a cell against concentration gradient. So if you have an increased expression of MDRI gene, is going to increase the effect of the P-glycoprotein drug transporter, and there will be an efflux of the drug outside the cell. So that's about the multi-drug resistance. Now just to revise few diseases and the regimens, Hodgkin's, MOPP and ABVD regimen. For gastrointestinal and for solid tumors, that's the visceral tumors including colorectal carcinomas, 5-FU, that's 5-fluorouracil. For carcinoma breast, 2 drugs. Number 1 is tamoxifen, a selective estrogen receptor modulator, and trastuzumab, a monoclonal antibody against HER2 surface receptor protein. For CML, which we already revised, busulfan, imatinib, and hydroxyurea. For brain tumors, the drugs which have got good penetration, so those are the nitrosoureas, carmustine and lomustine, good CNS penetration, so for brain tumors. For CLL, chlorambucil and melphalan. So this was the revision of some of the carcinomas and the drugs which are more commonly used. Please remember, the drugs are more effective against the tumors with a high growth fraction, and these are the cells which are large percentage of actively dividing or replicating cells. So the normal cells inside our body with high growth fraction like bone marrow, they are going to be more sensitive cells, and you're going to get more toxicity as far as the rapidly multiplying normal cells of the body are concerned. As far as bone marrow suppression is concerned, let's revise once again. Vinblastine, nitrosoureas, cyclophosphamide, cytarabine and doxorubicin are bone marrow toxic agents. Carboplatin, procarbazine, etoposide, methotrexate and 5-FU also do produce more bone marrow suppression. Whereas bone marrow sparing agents are bleomycin, vincristine, cisplatin, prednisone and L-asparaginase. So these have got marrow sparing effect. The bone marrow suppression is comparatively less. So these drugs are called as marrow sparing. Bleomycin, vincristine, cisplatin, prednisone and L-asparaginase. Lastly, few words about Kaposisarcoma. It's a multifocal malignant neoplasm, and it involves the primitive vasoformative tissue, that's the skin, the lymph nodes or viscera may be involved. And in Kaposisarcoma, you get cutaneous lesions. There's reddish purple or dark blue macules, plaques or nodules. So that's the characteristic lesion of Kaposisarcoma. Spindle cells and vascular spaces, they are infiltrated by hemosiderin pigmented macrophages and extravasated RBCs. So this is about some pathophysiology of Kaposisarcoma, and the drugs useful for Kaposisarcoma is your anthracyclines, that's doxorubicin and daunorubicin in the first place. Then you can also use interferon alpha 2A, alpha 2B, and you can also use paclitaxel. Kaposisarcoma is found more in the males, especially more than 60 years of age, is commonly associated with HIV disease, that's AIDS, and also another association is human herpes virus 8. So these are some salient points about Kaposisarcoma, and the drugs of choice are doxorubicin, daunorubicin, and the interferons as well as paclitaxel. So on this module, we completed the chapter of anti-cancer agents, and we did anti-cancer agents in 4 different sessions. I would advise you to go to all the 4 sessions and do it at a stretch, and then it will be extremely useful. Thank you very much for listening, and best luck.